Yesterday, Dr. Imad has 2 lectures, right?
Yes.
He's taken 2. So tomorrow there will be no lecture of Dr. Imad.
Yes.
Did you take 2 attendance for that one?
No, we didn't have time because there was a class in female pages. We only took 1 time.
So what you can do, tomorrow is Dr. Muna's lecture, right? After Dr. Muna's lecture, open the podium for Dr. Imad and then have both attendance there, right? So you will be having 4. So tomorrow we will be having only probably 1 lecture, that is of Dr. No, I think 2 lectures. One is Dr. Gavan, which is from, and they are separate lectures. I think it's 2 to 3 for female and 3 to 4 for male, if I'm not wrong. Can you open the schedule and confirm? It is Dr. Gavan, right? I don't know, because if 3 to 4 is available, this lecture hall, then he can have a combined lecture.
It's on Wednesday.
Huh?
It's on Wednesday.
Oh, and not today.
No, Dr.
Today is, okay, today is my lecture and Dr. Wissam, 9 to 10. Okay. On Thursday, we have Dr. Dilip's lecture, right?
No, it's on Wednesday.
Huh?
It's on Wednesday.
On Thursday, again, I think it has male and female separate.
Let me see.
Uh, from 11 to 12, it is male, and it is 1 to 2 for female.
No, actually, Doctor, the common department is last. So our lecture is from
Who?
Dr.
Dr.
Bashar.
Rasha.
Yes. Let me check. Doctor, we have a long class on Thursday from 9 to 10 and 10 to 11. And we have pharma from 1 to 2 on Tuesday. It's combined.
It's combined,
Yeah.
1 to 2. Dr. Dilip,
Uh,
which will be taken by Dr. Atuf. And this is the same lecture hall,
yeah.
1 to 2. Confirm. It is there in the Moodle?
Yeah, it's on the same.
Because when I opened the Moodle, it was not showing like that.
Was it showing?
Okay. Yesterday we stopped the lecture here. So this was endometrioid tumor, and I was showing you the cystic and solid areas. But if you see the glands are just like endometrial gland. So this is a clear-cut indication, as if you are looking at the endometrium, right? So this is endometrioid tumor, and some of the gland is entering into this tumors area. So it's a endometrioid tumor, malignant one. Now we have clear cell carcinoma. Clear cell carcinoma of the ovary. So it's uncommon. It's not that much frequently seen, and it is characterized by a large epithelial cells, just like what we see. Whose pointer is this? Okay. Sorry?
We have an updated schedule for papers last week. Yeah, it's not on YouTube, but you can do it.
So it's confirmed that 1 to 2 is a combined lecture of Dr. Okay. So it has a clear cytoplasm, right? And it's just like a hypersecretory gestational endometrium, if you see. And it has also associated with endometriosis and endometrioid carcinoma. So it can also change into resembles a clear cell carcinoma of the endometrium. They have a solid neoplasm. They are arranged in sheets as well as in tubules. If it is tubule, it is a glandular-like, and if it is a large gland forming a cyst, then the lining space is of a large cells with a clear cytoplasm. The 5-year survival rate is approximately 65%, and the tumor is if the tumor is confined to ovary. However, if the tumor is aggressive, spread beyond the ovary, the 5-year survival rate is very bad, right? Clear cell carcinoma, we don't have a good prognosis. Now coming to cyst adenofibroma. Now these are a very typical tumor. I have never seen in my clinical life, although they say that's a benign, borderline and malignant, but I have only seen a benign lesion. So they have extensive area of fibrous tissue proliferation, and on the top it's a lining of simple columnar epithelium. So they have a small papillary processes which is lined by simple columnar epithelium, and borderline lesion or typical cell can be seen, but malignancy is extremely uncommon. So if it is uncommon, metastasis is not there, right? This is how it looks like. So it's very solid. See, like this. This is very solid, and if you see this histology, this is all fibrous tissue proliferation, and it is lined by columnar epithelium. Although it is not very much visible here, but it is tall columnar epithelium lining this fibrous tissue. And because of this fibrous tissue, they are very hard. You can see with the gross picture. Coming to Brenner's tumor, this is also a type of adenofibroma, but it has an epithelium of transitional-like epithelium. Where do you see transitional epithelium? In a urinary bladder. So it is just remiscenting like you are looking at urinary bladder. They have again solid and cystic areas. Mostly it is unilateral, but bilaterality is also seen. It is as small as 1 centimeter and as big as 20 to 30 centimeter. The fibrous stroma is resembling normal ovary. With them, it is in between. You can see a nest of transitional epithelium. So this is how it looks like. If you see cut surface, there are cystic areas, solid area, cystic area, and these are the fibrous area, fibrous tissue, with the nests of these transitional type of epithelium, another nest, another nest. So it has a typical picture. So if you see Brenner's tumor, you will recognize that's a Brenner tumor. It's totally, this is one of these type of specific type of tumor that you will never forget once you see it. Okay. Now, as I was saying again and again, kindly go through the pictures. My pictures, my lectures picture, Dr. Imad, Dr. Radiology, and also Dr. Mohabbat. So for your preparation of the exam, just go through the lectures and see the pictures, because you will be having 10 questions of OSPI. Each question carries 1 mark. So you have 10 marks of OSPI. You can grab all of these 10 marks by looking at the pictures, right? So that will be good for you. Even I have put some of the pictures in my MCQs also, that will help you. So if you know the picture, you will know the diagnosis. Okay, then clinical course, all of the tumor has a similar clinical course. So the most important is the lower abdominal pain and abdominal enlargement, as you have seen in the mucinous carcinoma. You can see the gastrointestinal complaint, because if the tumor is huge, they usually compress the intestine. You can have a urinary frequency, dysuria, pelvic pressure, and the symptoms of progressive weakness, weight loss, and cachexia. You know what is cachexia? Weight loss, extremely weight loss. And the patient looks like very thin and lean, hardly able to walk, right? So thin that we call it cachexia. And you know what is the cytokine which do that? TNF. Okay. Now, if the carcinoma extend through the capsule of the tumor, it enters into the peritoneum, and as it enters into the peritoneum, it causes ascites. You know what is ascites? Fluid in the peritoneum. So the abdomen become hugely enlarged, right? And when you take the tap from the peritoneum, it will show tumor cells, malignant cells. And usually you can see omental caking, which is 0.1 to 0.5 centimeter, multiple caking around the whole peritoneum. And if you just take a biopsy of it, you will see a malignant cell there. Then renal lymph nodes are also involved, and it can go up to liver, lung, and gastrointestinal tract. And it can also shift from one ovary to the other half of the ovary. And usually what happens when you diagnose the case already has gone outside the ovary, right? So it's not no more confined to the ovary. And the 5 years to 10 year survival rate of the patients are low, not like other diseases, because when you have seen, it has already been. So we are looking for the specific marker to identify tumor as soon as possible. So one marker is CA125. 125 is a good marker, specific marker. It's a high molecular weight glycoprotein. But 80% of serous and endometrioid carcinoma show positively for that. But the clinch or the other adverse reason is that this is also positive in non-neoplastic condition like endometriosis and inflammation. So now we are also looking for some more specific one. So osteopontine is another marker which we are still working on it. Maybe a time will come, because they show more higher level of ovarian cancer patients are seen. So probably in future we will be having a good marker or like this one. So this is for the lecture which yesterday. Now today we will be starting a new one. This one, good. So this is basically, we have done the epithelial tumor, right, as we have discussed. Now we are going towards the germ cell and sex cord stromal one. So germ cell, it is 15 to 20% of them, 3 to 5% are malignant, and usually it is seen in a younger patient also, from the birth of the child till 25 years, but it can be seen. They are teratoma, disseminoma, endodermal sinus tumor, choriocarcinomas. Sex cord stromal tumor, they are just 5 to 10%, 2 to 3% are malignant. All ages are there. For example, from teenagers to 65, 70, fibroma, thecoma, they usually occurs together. Granulosa cell or thicker cell tumor, then we have sartoli-lytic cell tumor, and finally metastasis. Usually it comes from GI, and when it lodges into the ovary, we call that thing as a Krukenberg tumor, Krukenberg. and I will show you a beautiful slide of that. So germ cells, as you say, as we have seen, it is 15 to 20% of all malignant tumors, and it is found principally in the children and young adult, usually in a younger age, and it has mostly malignant behavior. If you see this germ cell tumor, it is just like same as you see in a testis. So testicular neoplasm and ovarian neoplasm are almost same, no difference. This is the chart which shows classification, mature and embryonal type. The mature comes the benign and malignant. Benign are cystic teratoma and struma ovari. The malignant one are, the most common is squamous cell carcinoma, but carcinoid and thyroid carcinoma can also be seen. In embryonal type, means primitive type, we have undifferentiated, in which we have dysgerminoma, trophoblast, which we have choriocarcinoma. This trophoblast is just like we see in placenta, right? I think Dr. Imad has taken this one, okay? But the difference is placental choriocarcinoma, they had a good prognosis when you treat, but ovarian chorio is not that much good for the treatment. Now, primitive one, embryonal carcinoma, somatic one is immature teratoma, and extra-embryonic one is yolk cell tumor. So we will discuss one by one. Starting from teratoma, most common one, there are three categories. One is benign, immature, and monodermal. Benign is a benign, which we usually call a dermoid cyst. Immature is malignant. So we'll see what are these different parts which becoming malignant, and then monodermal are highly specialized. So this benign tumor, as I said, is usually called a dermoid cyst, and it is seen in a woman with active reproductive life, means 20 to 35, 40 years of age. So it's most commonly seen there. Benign teratoma, less commonly, means 10 to 15% are bilateral. Usually they are unilateral, and they have a unilocular, one cyst. And if you just cut it, you will see hair and cheesy material. So what other thing you see, thin wall means skin, and grey-white wrinkled epidermis because of the skin. In this, which you see hair shafts, and also tooths or teeth, rather 2 or 3 teeth are visible from the naked eye. And morphologically, again, because of the epidermis, the skin, you will see stratified squamous epithelium, and below that you will see a sebaceous gland, hair shaft, and inflammatory cells, and skin adnexa. What is skin adnexa? They are sebaceous glands, sweat glands. They are called adnexa, skin adnexa. Most cases, the structure of other germ cells are also seen, like cartilage, bone, thyroid tissue, neural tissue. So because it is totipotential, so any type of lineage you can be seen. 1% may develop malignancy, and most of them is squamous cell carcinoma. However, thyroid carcinoma and melanomas can also be seen. This is how it looks like. So if you see it carefully, we have one unilocular cyst, and when you cut it, the fluid has taken out. These are the hair shaft. It's very little amount of hair shaft. Sometimes you see a bundle of hairs, like a roll of a hair bundle. These are the teeth. 1, 2, 3. These are sebaceous area or sebum. And if you cut it and see under microscope, this is stratified squamous epithelium of the skin. These are sebum. These are skin adnexa. These are hair follicles, and a lot of inflammatory cells. Here it is not shown, but you can see cartilage, bone, muscles, anything can be seen here. But they all are mature, so benign. Monodermal or specialized type, we have two important ones. One is struma ovari and struma carcinoid. In struma ovari, what you see, a mature thyroid tissue, right? It is lined by cuboidal epithelium, and it is filled with thyroglobulin. Now the important thing is, sometimes they secrete thyroid hormone, and sometimes it becomes hyperfunction. So a female comes to you with a normal thyroid gland, and still she had symptoms of hyperthyroidism. So never forget that she might have struma ovari. It should be in your mind. The other one is tumor, carcinoid, and you all know that carcinoid tumors usually develop in the intestine. The most important area or organ is terminal ileum or appendix. Okay, if it is less than 2 centimeter, carcinoid remains there without any signs and symptoms. But if it is more than 2 centimeter or larger than 7 centimeter, then they secrete more and more 5-hydroxytryptamine, which is then show carcinoid syndrome. And I'm sure you know what is carcinoid syndrome, right? Flushing of the face, skin, diarrhea, increased mortality, and increased heart rate. So these are the symptoms which you see. So primary ovarian carcinoid can be distinguished from metastatic. Now yes, metastatic carcinoid can also be there. For example, it is in the appendix, it has entered into the ovary. How will you differentiate? It will be bilateral. As I said, whenever there is metastasis, it should be bilateral. So if it is bilateral carcinoid, go and look for intestinal carcinoid first. Now, sometimes it happens that both of them occurs in the same ovary, means struma ovari and struma carcinoid in the same size, and it can metastasize. So this area is struma ovari, in which you can see that these are well-formed thyroid follicle and divided epithelium roughly ovine, okay, but larger in number. Sometimes they secrete excessive amount of thyroid hormone. This is struma carcinoid. You can see nests of cells on protonous cell having rounded nuclei, and in the nuclei, if you see carefully, it is salt and pepper appearance. Salt and pepper. A peculiar appearance of carcinoid. Right? Clear? I'll show this picture. Can you identify? Yes? Remember pictures, remember? It will help you in many areas. Immature malignant teratomas, as the name says, immature means malignant. Usually the age benign, mean age is 18 years, but plus minus fluctuating one, resemble embryonal or immature type. It has necrosis and hemorrhage, and you see again same things like hair, sebaceous material, cartilage, bone, and calcification. Now in this one, important thing is immature neuroepithelium. Neuroepithelium is very important to classify or grade the tumor, and it is graded from 1 to 3. If the neuroepithelium is more than 50%, then you call it grade 3. If it is less than 10%, you call it grade 1. And if it is in between, you call it grade 2, right? So it all depends how much neuroepithelium is there. But along with the neuroepithelium, you see all of them, cartilage, bone, and other structure, muscle structure, they are all immature, not a mature one. And they grow very rapidly. They can penetrate into the capsule and go distant metastasis. Stage 1 tumor, particularly if it's confined to the ovary, it has an excellent prognosis. But higher grade, and again it is confined to ovary, if you treat prophylactically by chemotherapy, again recurrence develops within 2 years of time. So this is how it looks like. So if you see, this is a gross picture in which these are cystic area, these are solid area. This whitish structure, this is called neuropil. What is called? Neuropil. So as you see here, majority of the ovary is being occupied by neuropil. So it is grade 3 because it's more than 50%. If you do see under microscope, these are all all very small area of the structures, but they all will be immature. Clear? coming to dysgerminoma. Dysgerminoma is a counterpart of seminoma in male testis. If you show me a slide of dysgerminoma without telling me that it is from ovary, maybe I will say it is seminoma. It's so resemblance. So it is 2% of all ovarian tumor and occurs in childhood, but 75% again occur in second to third decade of life. Usually it is unilateral, about 80 to 90%. Similar to seminoma, composed of large vesicular cells. So if you see this slide, you will see large vesicular sheets of large with clear cytoplasm, and they have septa in which there is infiltration of lymphocyte. Occasional granulomas may also be identified. So if you see in blood, the chorionic gonadotrophin hormone will be high, and because of the syncytial trophoblast giant cells in this one, they are also positive for c-KIT. So if you do immunoperoxidase staining, it will be positive for that. This is actually a diagnostic marker. Clinical features: dysgerminoma are all malignant, and it is one. They are very aggressive. Unilateral tumor, and it has not broken through the capsule. If it is there, the prognosis is very good. 96% cure rate, and if you do just simple salpingo-oophorectomy, means fallopian tube and ovaries are being removed. These neoplasms are responsive to chemotherapy, are very much responsive to that. And as I was telling you, nowadays the chemotherapy has developed a lot. There was a time when we used to say that it is better not to give chemotherapy, let the patient die peacefully. But now the chemotherapy has tremendously improved. Even colonic carcinoma and other GI tumors, ovarian tumors, they respond exceptionally good. So I think one should go with this one. Overall survival rate exceed 80%, so good one. This is how it looks like. So in the gross picture you can see solid areas, mostly variegated appearance, right? These are necrosis, necrotic is also there. And histologically, if you see, these cells are arranged in sheets, right? And the clear cytoplasm around rounded nuclei. And these are the septa. This is one septa, this is another septa. And in these septa, you see lymphocytes. So these smaller, rounded, wired cells, they are lymphocytes. So these are mostly present in the septal area. So if you see a slide of seminoma, it is exactly the same. If you stain PS, it will be highly positive, right? PS stain. Okay, this is, now we are coming to endodermal silence tumor, which is Yolk-sac tumor. This is also one of the most, dangerous tumor, second most common of the germ cells. They are usually seen in children and young women. They cause abdominal pain and pelvic mass. Now, these are mostly malignant, extra-abdominal Yolk-sac. They are rich in alpha-fetoprotein and alpha-1 antitrypsin. So they have a peculiar glomerular structure, right, in a central blood vessel surrounded by germ cells. They are called Schüller dual bodies. Schüller dual bodies. The rest of the tumor is just like a lace-like structure, right? Ladies must be knowing the lace which they used to take it from the market. So they have a cupus intracellular and extracellular hyaline droplet. This is also one of the diagnostic feature. But if you stain alpha fetoprotein, that will be strongly positive for immunohistochemistry or immunoperoxidase technique. Again, usually a single ovary is involved, and the 2 years survival rate in the 2 years diagnosis and the combination of therapy, it is not that much. It was a time when it was considered that you have Yolk-sac tumor, the patient, whatever you do, will die. within 2 years of time. But because of this chemotherapy combination, usually patients survive for another 3 or 4 years. But it's a lethal type of tumor. This is how it looks like. You see, cut surface mostly solid, yellowish in appearance. This is a lace-like pattern, and this is Schiller dual body, central blood vessel surrounded by these small germ cells surrounding the blood vessel, Schiller dual body. Now coming to the choriocarcinoma, as you know, choriocarcinoma, just like in placenta, just like in testis, it is there in the ovary, and they are all malignant cells. And at the time of diagnosis, when you see the patient, it has been already metastasized from the ovary. It is very aggressive tumor. So it can metastasize through blood stream to lung, liver, bone, even into the brain. I think I remember one case in which I was received a brain biopsy which was showing a choriocarcinoma there. And surprisingly, because of the aggressive nature, the size of the ovary remains small, because they tremendously increase and then they necrose. So the size remains the same. It's not so big, but it can reach anywhere you want. It can go to liver, bones, brain, wherever they want. Lungs. So like all choriocarcinoma, they elaborate chorionic gonadotrophin. Usually in pregnancy, a slight rise in HCG there, which is normal. If it is more increase, means the level reaches up to 800 or 1000, then you think of hereditary form more. If it is increased to thousands, 5,000, 6,000, 10,000, then you will think of choriocarcinoma, right? So in contrast to choriocarcinoma arising in placenta, arising in ovary, they are mostly unresponsive to chemotherapy. So the placental choriocarcinoma is better to be treated rather than the ovarian one, and usually often they become fatal. This is how it looks like. You just see how aggressive this tumor is. This is this is cytotrophoblast, this is syncytial trophoblast, and these are all necrotic tissue. Means these cells are proliferating in such a way that the blood supply does not cope up with their division. It divides so frequently, very fast, that when they don't get blood supply, they become necrotic. And as it is so aggressive, it goes into blood and reaches different part of the body. So the size of the ovary will remain smaller. Other germ cell tumor are embryonal carcinoma, polyembryoma, and mixed germ cell tumor. Mixed germ cell tumor, either you have dysgerminoma with teratoma, endodermal sinus tumor with choriocarcinoma. So it's a mixture of two. Any of the two can be joined together. Now coming to sex cord and stromal tumor, we have two important ones. One is granulosa theca cell tumor, and the other one is Sartori-Lytic cell tumor. Starting with granulosa theca cell tumor, again, these are all malignant tumor, but if you see the morphology, you will not be able to diagnose that this is malignant. So bland, so mild. So they are composed of granulosa cells mixture with the theca cells. So it's a granulosa and theca cell tumor together. They account for 5% of all ovarian tumor, and 2/3 of them usually present in post-menopausal women. So usually it starts in a later age group. But there is another variant which is called juvenile, which we will be discussing now. So usually they are unilateral, had solid, cystic, and a large encapsulated mass. They have yellow coloration because they secrete hormone, right? That's why they are yellow. And they have intracellular lipid, small cuboidal polygonal cell, and they are arranged in sheets and cords. Remember one thing, the cells looks like a coffee bean appearance. Coffee bean. It's a peculiarity of the granulosa cell. So sometimes it looks like a glandular structure with the central have an acidophilic material. So now this is called cord external body. In yolk sac tumor it was Schiller dual body. Here it is called cord external body. So thecoma component consists of a sheets of cuboidal to polygonal cell. Clinically, there are two important things to be noted. One, secretion of estrogen from this tumor and hazard of malignancy. They look so bland and you are not convinced to call it malignancy or malignant, but they are malignant. So functionally active in a young woman, they are called juvenile granulosa cell. As I said, they can occur at the age of 8 to 9 years old. So these girls, they show precocious sexual development in a pre-pubertal girl. So they have early development of breast and probably early menarche. They can also masturbate at the age of 7-8 years. So the adult woman may have associated with endometrial hyperplasia. Why? Because they are secreting estrogen. So estrogen not only causing endometrial hyperplasia, but also they cause cystic disease of the breast, and later on 10 to 15% they can cause also development of endometrial carcinoma. All granular cells are potentially malignant. I have never ever seen in my clinical life benign or borderline granular cell. They are all malignant. So they are all malignant, ranging to 5 to 25%. This is how it looks like. So you see it's yellowish coloration because of the secretion of estrogen. So they have droplets, lipid droplets. So they are yellowish in color. And here, if you see, these are sheets of cells. Isn't it looking like a coffee bean? Have you seen coffee beans? So they are little smaller angular one, right? Like this one, and they have a groove also. And when they come together and form a granular pattern, and in center there is an acidophilic material here, here. They are now called, or this is the diagnostic feature of percent. Clear? It is a bit difficult, I know, for third year level, but if you go and see these pictures again and again, you can be easily differentiate between cord external and Schiller dual, right? We are not telling you many of the tumors. We skip just important one we are telling you, so that looking at your third year level. Now we have other tumors, fibroma, thecomas and fibrothecomas. Usually they are combined. We have never seen fibroma alone. So it is usually, and they are 4% of the tumor. Mostly they are benign. They are mixture of fibrothecoma. Pure thecomas are not there. Fibromas, they have, they are usually present in 90% of the ovary. They are solid spherical one. Again, some theca element is there. They are very hard. Fibrosis, sclerosis means hard. So hard, grayish white, covered with glistening ovarian serosa. Histologically, they are well differentiated fibroblast. So spindle cell nuclei along with the theca element. So this is how it looks like. So if you see, they are oval shaped and they are so hard. If you just cut it with the knife, it is really difficult for you to cut it because of the hardness of the fibrosis. Now, the smaller cells, like this one, these are fibroma or fibrous tissue elements. The plump, more thicker, these are thecoma cells. Clear? So the smaller spindle cells, they are fibrous tissue. The larger oval plump are theca cells. So this is fibrothecoma. Now sartolytics. This is another tumor of the ovary, although they are mostly seen in the testis. less commonly seen in ovary, but it has the same effect. Masculinization and defeminization means either they produce some masculine activity like mustaches, right? Um, Very coarse voice if this tumor develop in female. Or defeminization means if the female has breast, it will shrink down, or because of, but they have some of the estrogenic effect also present in all ages. Peak incidence is on second to third decade of life. So as I said, that granulosa and theca cell element, they are usually seen together, and metastasis can also take place, but it is less than 5%. Cut surface shows solid golden brown in appearance. Now that was yellowish in appearance. Here it is golden brown in appearance, and they are well differentiated, and you can see tubules. If it is well differentiated, you will see a well-formed glandular pattern. Then you will see it's a well differentiated. When it is intermediate, so what will you see? You will see some of the glands, and some of them are half glands, right? So we call it intermediate. And if it is poorly differentiated, means you will hardly see any of the glandular structure, only you will see spindle cells, so sarcomatoid pattern. Lytic cells may be absent, and only Sartoli cell will be there. They have mucinous gland, bone and cartilage present in some of the tumor, not all. And what they say is they block normal female sexual development because they secrete androgens. So they cause defeminization. So the woman, they have atrophy of the breast, they have amenorrhea, sterility, and loss of hair. So these are mostly masculinization or defeminization effect. The syndrome is tracking virilization in which or hirsutism, mustaches, male distribution of hair, hypertrophy of the clitoris, and voice changes. Usually female has a very high pitched voice, rather it becomes low. Okay, so this is how it looks like, golden brown in appearance. This is area of necrosis. Mostly they are solid, there are no cystic areas. Now this glandular structure show that we are dealing with a well differentiated one, because majority of the glands are there, right? Now this is Sartoli cells. These are Lytic cells. These are Lytic cells which are present in between the glands. Clear? So Lytic cells are present in between lines. These are Sartoli cells. And here there is some breakage of the gland. So in intermediate form, it looks sometimes look like this one, half gland. But usually it's a big, normally big, well differentiated. So I would say it's a well differentiated sarcolytic type of a tumor. Metastatic tumor, usually it arises from other lineage, from uterus, fallopian tube, or contralateral ovary. Mostly we have seen that they are coming from breast, gastrointestinal tract, colon, biliary tract, and pancreas. They include also the pseudomyxoma peritoni, as said. So the appendix is always used to be seen, as I said, if they are bilateral ovarian enlargement. So you just go for appendix. So there is mostly they arise from gastrointestinal, means gastric origin, and we call this thing as a Krukenberg tumor when you see a mucin producing signature type of cells, right? If this is specifically peculiar of the tumor, if you just see a signet ring, means it is coming from the GI tract, stomach. If it is coming from colon, you might see some glandular structure also, but here you don't see any glands, right? So if you see the histological picture, this is ovary. You cut it, you see a pool of mucin in which you have some cells, little more high power, you see but individual cells, not forming line. Further high power, you see these cells look like signet ring. Why we call it signet ring? Look like a ring. For example, this ring. Nucleus, cytoplasm, right? So that's why they call signet ring. Again, just compare nucleus, cytoplasm. So if you see such a group of cells in nest, you call it hook and bug. Again, I will say, go through the pictures again and again. This is what we used to do. As a student, we used to make a group of friends, and this group, we see the picture and we ask the other friend to please ask me which picture is this. So the other friend used to show the picture and the other was telling him this is picture. And next time you are going to ask from him or her. So this is the best way. Remember, medical education or medical studies are not the study which you do in a closed room. Remember, if you want to be a good doctor, if you want to retain the thing, make a group of girls or boys. And then give you full time for your studies, and in the morning or afternoon, get together and then discuss whatever you have learned. By this, you will retain the things. Otherwise, it is so volatile that today you have remembered or learned, tomorrow is all gone, right? So when you come in 4th year, and if I'll be taking classes of that, and if I ask something, why? Because you are not discussing the things together. And it is also good for you in your USMLE exam. Remember, you are not actually learning the thing for this 3rd year exam. You are learning this thing for your USMLE exam. Your initial goal will be either USMLE or PLAB or these type of exam, because staying here after MBBS is nowadays nothing. You had to be a postgraduate, and I feel proud when my student, now I see somebody come to my office, sir, Dr. Abrar, Assalamu alaikum, where are you? Sir, I'm consultant in KFSH. Huh? Oh, nice. So, sir, I was your student and I did this, and I'm now doing surgeon. And that make us proud that our students are now getting specialized in some of the areas. Never ever think that this MBBS is the last goal. You have to look forward. Clear? Any question regarding this one? Remember, even this is my last lecture today. We'll be having CPC, right, next week. I will try to have that CPC combined from 10 to 12. So 8 to 9, 9 to 10, I will give these lecture to Santosh and Dr. Aduf. So first 2 lectures will be those, and then 10 to 12 we'll be having CPC, in which you will be having chance of discussion. So I will make groups as we did last time, and then I will show you the cases, and then you will discuss with each other, making your own, because there will be some of the SAQ type of questions, some of them will be MCQ. So that will be a practice how the questions are given in your exam. I hope you will like that one. Even then, if you have any problem, anything which you have not understood, please kindly come to me in my office. There was one question I have received from the students, and I know that you're right, regarding the ketone bodies and ketoacidosis. So I said lipase, which can ask the, more and more fatty acid from the fatty depot, right? So if you just open a book 1 year back, means now we are looking at 11th edition. If you see the 10th edition, you will see the same what I have mentioned there. But thank you very much in informing me, because when I saw that the same thing, but just a slight change in the name, but it is the same lipase. Okay, so don't be mixed up with that one. If you just open my lecture of ketoacidosis, so just one word, which is lipase, which is hormonal lipase in a new one, but I have used the other one. So please be careful, and this is one and the same thing, but they have changed the name for that one. Okay, but if you have any difficulty, anything which is not been understood, my office is in third floor, S376. My doors are always open. You can anytime come to me and say that, Dr. Brar, we are not understanding this thing. Will you please explain me again? I will explain it. Okay? Thank you very much. Please kindly take the attendance. Taali hai na? And after my lecture, Dr. Visam will come, and I will ask you to take her attendance now, because just after that you will be having the PBL. Huh?
Yeah.
Okay, so this will be the last PBL. So what will you do is, you will discuss third PBL first, and then the last half an hour, 45 minutes, you will be discussing the new case, fourth one. And then on Thursday, we will be finishing that one. Okay? Thank you very much.
Doctor,
Yes.